Hello, my name is Rosemary Morgan and I'm on faculty at the Johns Hopkins Bloomberg School of Public Health. And today I'm going to be talking about COVID-19 and the need for gender-responsive pandemic preparedness and response plans. We know from past experiences that pandemics like COVID-19 are not gender neutral. It is important to think about how men and women, as well as people of other genders, are differentially impacted. Some effects are more immediate, while others are more long-term, and there will be differential health, social, and economic impacts. When discussing the gendered impacts of pandemics, we must also look at differences not only between, but among men and women and people of other genders. By considering how a gender intersects with other social stratifiers like race, age, income, disability, sexual orientation, to create individual experiences of marginalization and vulnerability. One point I want to stress here is that the response to the gendered impacts of COVID-19 is not a zero-sum game. Talking about how one group is impacted does not mean that the ways in which other groups are impacted are not important. And the evidence clearly shows that everyone is better off when societies are more equitable. Despite pandemics not being gender neutral, global policy created to respond to outbreaks and implemented nationally is gender neutral by not recognizing differential effects. The current COVID-19 pandemic has both primary short-term and secondary long-term effects related to both sex and gender. However, outbreak responses consistently fail to meaningfully include gender analysis. Primary effects include greater severity of disease and mortality among men and infection risk among women healthcare workers. There are biological differences between men and women in relation to their immune responses to viruses, with women typically having more robust immune responses. Reasons for men's higher rates of mortality, however, are likely to be both biological and behavioral, related to both sex and gender. Behavioral activities such as smoking or vaping, lack of hand washing, and delayed healthcare seeking may be putting men at greater risk of mortality. Presence of comorbidities such as diabetes, hypertension, or cardiovascular diseases may also be increasing men's vulnerability. We saw a similar pattern during the SARS and MERS outbreaks, with more women than men being infected by SARS in Hong Kong, for example. The death rate was still higher among men. One primary short-term effect we are seeing is in relation to the infection rate among healthcare workers. Women are on the front lines as healthcare workers and primary caregivers, providing 75% of the health and social care workforce. At the same time, they are being disproportionately infected by COVID-19. In some countries, COVID-19 infections among women healthcare workers are twice that of men. This graph shows confirmed cases among healthcare workers of COVID-19 in Italy, the US, Spain, and Germany. In each country, we see a higher proportion of female healthcare workers infected with COVID. I'd like to now focus on some of the secondary long-term gendered effects that we are seeing, one of which is related to women's economic security. The majority of low-wage and part-time workers are women, and many of them are women of color. Such workers have greater income insecurity and face greater risk if and when their places of work are shut down. We can also draw on lessons from past epidemics to see how women's livelihoods may be affected. During Ebola, for example, quarantine measures closed markets, destroying the livelihoods of traders, the majority of whom were women. Men also lost their jobs, but 13 months after the first case was detected, 63% of men had returned to work compared to only 17% of women. This graph shows occupations by the share of women who are employed in the sector and whether an occupation is seen as feminized. Those on the left have low occupational feminization, while those on the right have high occupational feminization. The three occupations with the highest COVID-19 occupational risk scores are highly feminized essential occupations, where women account for at least 7 in every 10 workers. I'd like to return now to the issue of women healthcare workers being disproportionately infected. One reason might be related to personal protective equipment and how they are being made for the male body as the norm. We are seeing increasing reports of women healthcare workers failing their fit tests, which shows whether PPE is effective or not, or they don't have equipment at all, which makes them more vulnerable to infection. We know that viral load, that the viral load that one is exposed to affects the seriousness of infection. Workers in high health facilities, for example, are more likely to be exposed to higher viral loads. Healthcare workers, including nurses, which are predominantly women, must have adequate protection. Another gendered effect is related to women's representation within decision-making bodies. Women are not equally represented in decision-making roles responding to the COVID-19 pandemic. Evidence shows that when women have less decision-making power than men, their needs during an epidemic are less likely to be met. Take a look at this figure from Operation 50/50. This shows that the White House Coronavirus Task Force was over 90% men, and in the United Kingdom, the response was all men in the beginning. Only 20% of the World Health Organization Emergency Committee on COVID-19 are women. And given women's frontline interaction with communities, it is concerning that they have not been fully incorporated into global health security surveillance, detection, and prevention mechanisms. Women's socially prescribed care roles typically place them in a prime position to identify trends at the local level that might signal to the start of an outbreak and thus improve global health security. What are some other secondary long-term effects that we are seeing? Well, evidence shows that there are increased rates of domestic violence as a result of social distancing and quarantine, which predominantly affects women. The Ebola epidemic in Sierra Leone saw an increase in maternal, neonatal, and stillbirth deaths, and a reduction of routine vaccination programs as a result of a diversion of resources towards Ebola. And we are likely to see similar effects in relation to COVID-19, with resources being diverted away from sexual and reproductive health and maternal health care. Informal care is also gendered. Evidence shows that the majority of childcare and caring for elderly parents is still done by women. And the pandemic is only exacerbating this. In the United States, women perform an average of 241 minutes of unpaid labor every day, which includes cooking, cleaning, caregiving, compared to men's 145 minutes. We see similar rates throughout the world, and sometimes it's even a greater gap. And as schools and nurseries close and remain closed, and elderly and vulnerable relatives need more help with errands, women will continue to carry the extra burden. So much attention of the gendered effects of COVID-19 has been focused on men and women. However, we must not forget that gender is non-binary, and nor should our response to it be. Gender minorities across the globe are being negatively impacted by the pandemic and the response to it. In an effort to maintain social distancing, for example, some governments have instigated gender-based rules which dictate which days of the week men and women are allowed to go outside. This has had negative impacts on transgender men and women who are already extremely marginalized. COVID-19 has also caused a delay in gender confirmation surgeries, which is likely to have severe mental health implications on the transgender community. Despite all this, we are still lacking sex desegregated data, or sex and gender desegregated data, which is surprising, especially due to the initial reports of how men and women and people of other genders are being differentially affected. Many countries are simply not reporting this data, or were not reporting on it in the beginning phases of the pandemic. In some countries, we know that this data was collected, but as cases began to grow, the data was aggregated, meaning that infection and mortality rates for men and women were combined. We can't respond to something if we don't see it. And our current data is inadequate. Not only is there little sex and gender desegregated data, there's even less data desegregated by other social stratifiers like race and disability, not to mention intersectional data looking at sex and gender with race or disability combined. Having accurate data is so important. If something is not measured and counted, it is treated as if it doesn't exist. A lot of the focus on the gendered effects of COVID-19 have also left out an important dimension, how not all men and not all women and not all people of other genders will have the same experiences of marginalization and vulnerability due to the ways in which gender intersects with other social stratifiers, such as race, disability, and class. I want to take a moment to look at the intersection of gender and race in the United States. In May of 2020, for example, nearly 23% of reported COVID-19 deaths were among African Americans, even though they make up roughly 13% of the US population. The reasons behind this are not biological, but social and structural. Yes, more men are dying from COVID-19, and women are more affected by the long-term social and economic impacts, but not all men and not all women are affected the same. I am currently involved in two projects that are looking at the gendered effects of COVID-19. One is titled Understanding and Mitigating Real-Time Differential Gendered Effects of the COVID-19 Outbreak. This project is undertaking a real-time, multifaceted gender analysis of preparedness and response mechanisms to provide immediate evidence to inform public health responses in comparative case studies in Canada, the UK, China, and Hong Kong. It's doing this through using document and policy review, chat room analysis, interviews, and social media analysis. And this project is supported by the Canadian Institute for Health Research. I'm also working on another project titled COVID-19 Gendered Risks, Impact and Response, Research and Policy Guidance. This project is also undertaking a real-time gender analysis of preparedness and response mechanisms. However, it's expanding the country focus and includes Bangladesh, Nigeria, Kenya, the Democratic Republic of Congo, and Brazil. And it's also using surveys as well as document and policy review and interviews. And this project is supported by the Bill and Melinda Gates Foundation. Another project I've been working on is in relation to the Gender and COVID-19 Working Group. So COVID-19 has really provided an opportunity to connect with others in ways that we haven't done before. And this working group came out in response to a Lancet article that we published in the early days of the pandemic on the gendered effects of COVID-19. Since then, the group has grown to over 300 members from academia, civil society, multilateral organizations, and government from across the globe, all with an interest in gender and COVID-19. It's being used as a platform to share resources and ideas and look for collaborations and bringing us together, as I said, in a way that we've never have before. Anyone is welcome to join, and you can send a message through the website. Many of us who study gender and health systems, particularly health systems in fragile and conflict-affected states, speak about the need to build back better, to build structures and responses which take into account gender and other inequities and respond to them accordingly. How can we expect to have equitable outcomes if the structures and processes in which we work are themselves inequitable? This pandemic has shown us that people are able to find different ways of working and are able to make accommodations for those who need it, including women and people with disabilities. This pandemic and our response to it is giving us a chance to reimagine the way things are currently done and to build back better. There is always an opportunity to come out of things and be better off, but only if appropriate and adequate responses are taken. This includes shining light on the inequalities within our societies and the structures within which we live and work, as well as ensuring our emergency preparedness response plans are gender responsive and consider the specific needs and vulnerabilities between and among women, men, and people of other genders. Thank you.